Hi, now we are going to discuss about the central nervous system, which is developed by the neural tube. So in this neural tube, it has rostral neuropore and caudal neuropore. Rostral neuropore is highly developed into this structure called as brain, which is very famous, and these all are developed into many parts, into three primary vesicles. I'm drawing a picture. And this is spinal cord. The first one is forebrain, and next one is midbrain, and next one is hindbrain, and this is spinal cord, and this is rostral neural tube. From this primary vesicles, it is again further classified into 5 secondary vesicles. Forebrain is into 2, telencephalon and diencephalon, and midbrain mesencephalon, and hindbrain metencephalon, and also myelencephalon. So derivatives of telencephalon, it consists of 2 lateral ventricles. And also cerebral hemispheres, and diencephalon has 1/3 ventricle, and it has thalamus. Mesencephalon has midbrain with no ventricle. Midbrain has no ventricles. It has only cerebral aqueduct. And many people might think this has second ventricle, but there is actually no secondary ventricle. Note this point. And metencephalon has pons and cerebellum, and myencephalon has medulla. These both together forms this 4th ventricle. This is between pons and medulla, 4th ventricle, and the remaining is spinal cord. Spinal cord has central canal, as we know this. Spinal cord is the simplest part of the brain, as most of this brain is developed from the rostral pore. So caudal neuropore is very little developed, and this diencephalon is very important here because it consists of 4 parts named ending with thalamus. One is thalamus, second one is hypothalamus, next one is subthalamus, next one is epithalamus, and retina, and optic nerve. Actually, there is a speciality for optic nerve, because optic nerve is not a nerve, it is a tract, because it is completely myelinated with the oligodendrocytes. And this thalamus, what does this thalamus do? Thalamus filters and relays this information to cortex, except olfactory nerves. And what does this hypothalamus do? It regulates the functions of the endocrine and autonomous nervous system. And epithalamus does this about the pineal gland. And the function of subthalamus, we'll see this detail in the next further coming topics. And there is a clinical correlate for this. That is, axonal polyneuropathies produce distal glove and stalk weakness or sensory deficits and are related to the axonal transport failure. Diabetes mellitus and mellitus patients present with sensory neuropathy. That is, what is polyneuropathy? This is diffuse dysfunction of nerves. So, axonal polyneuropathy, which produces glove and stalking weakness, the glove and stalking, or weakness or sensory deficits, which is related to axonal transport failure, and sensory neuropathies. These are seen in mostly diabetes patients. So that is it about the central nervous system. Now let's talk about this autonomic nervous system, which is controlled by the hypothalamus, which has motor innervations of smooth muscle, cardiac muscles, and also gland. So this autonomous nervous system is divided into sympathetic and parasympathetic. For these neurons to enter into any target tissue, either in sympathetic or parasympathetic, we need two neurons actually. So these are preganglionic and also postganglionic. I would like to tell something about these. That is, suppose I am showing you the rough diagram how it looks. These are cell bodies. This is some target tissue. This is preganglionic neuron. This is postganglionic neuron. This is pre. So we can see that this cell body of the preganglionic neuron is in CNS. That means it is derived from neural tube. As we all know that I told you previously, CNS neural tube, it's just marker. And also for this postganglionic cell body, this is derived from the neural crust. So this cell body of the preganglionic CNS, postganglionic cell body is PNS. Just remember this. And next we are going to talk about this peripheral nervous system, PNS, obviously. And if we make a rough diagram, this is parasympathetic, sympathetic, somatic. I wanted to tell you something. This parasympathetic is called as craniosacral outflow, and the sympathetic is called as thoracolumbar outflow. This is because of this nervous innervations. I'll discuss about this in detail later. So coming here, this parasympathetic or sympathetic is a two neuron pathway to innervate into the respective target tissues. So the preganglionic or postganglionic require some neurotransmitters. So what are the famous neurotransmitters we know? That is acetylcholine. This complete parasympathetic has an innervation of acetylcholine, either here or here before the target tissue or in postganglionic there. So this is acetylcholine, and this postganglionic cell body has the receptors of nicotinic receptors, and here again acetylcholine. So the parasympathetic nervous system just innervates to this muscarinic receptors here. That is various organs like heart, smooth muscles, glands. So just remember this, parasympathetic completely has only acetylcholine transmitter, that is cholinergic transmitters, and the receptor here is nicotinic receptor, and for target tissues it is muscarinic receptors. And for sympathetic, and also here I draw this very long because this preganglionic is very long in parasympathetic and postganglionic is short in this parasympathetic. This is long and this is short. So now in sympathetic, this preganglionic is short and this this postganglionic will be long. I'll tell you. So what will be the transmitters here? This may be acetylcholine. So for sympathetic, all preganglionic neurotransmitters are only acetylcholine. So we'll divide this into two ways. So this acetylcholine has same nicotinic receptors as parasympathetic. For example, if we take here it as adrenal medulla, we talked about this adrenal medulla, that is chromaffin cells migrate into adrenal medulla to form this postganglionic neurons. Yeah, that is it. For the formation and produces epinephrine. And also the receptors here are adrenergic. Adrenergic means that it will be alpha or beta, and these innervate into the various organs via blood. Epinephrine via blood, that is adrenal medulla. And next one here is, if you take postganglionic receptors, that is non-epinephrine, and again epinephrine or non-epinephrine innervates to this adrenergic receptors to various organs like heart, smooth muscles and glands. Yeah. And the main important thing of this sympathetic nervous system is it innervates body walls via muscarinic receptors by acetylcholine transmitter. That is acetylcholine here, muscarinic, this is A here, this is muscarinic, that is body wall. So what body wall consists of? Body wall consists of sweat glands, pyroerector muscles and all. The main important of the synaptic nervous system is this one, body wall. And we should remember this, that is acetylcholine here in all preganglionic of parasympathetic or sympathetic, and same nicotinic receptors. And parasympathetic has long preganglionic and short postganglionic. Sympathetic has short preganglionic and long postganglionic, except for this adrenal medulla. And yeah, this body wall is muscarinic receptor, acetylcholine, here epinephrine, adrenergic, non-epinephrine, adrenergic. Yep. And this somatic. This somatic has just one neuron pathway, because this is motor neuron and also innervates to the skeletal muscle. And this receptors here are non-muscarinic receptors, and the transmitter is acetylcholine. So actually you may think that this parasympathetic needs 2 neurons, sympathetic needs 2 neurons, and somatic needs only 1 neuron, but this is only half of the chart. because this requires an additional neuron which is called as a descending hypothalamic tract. So this parasympathetic or sympathetic needs 3 neurons to innervate, and somatic needs 2 neurons. We'll discuss in detail about this descending hypothalamus in coming chapters. And if someone asks you the question about which receptors control the secretions in body, so as we know that body wall is innervated by sympathetic acetylcholine muscarinic receptors. So it is muscarinic receptors which regulates the body secretions. So coming into parasympathetic nervous system, I drew a rough diagram here. Don't laugh, it might be funny, but it's okay. Just remember this, that is enough. So I told you this parasympathetic is also called as craniosacral outflow, because the nerves which are here are cranial nerves are 3, 7, 9 and 10. The sacral nerves here are S2, S3 and S4. So 3 is nothing but oculomotor, 7 is facial, 9 is glossopharyngeal, 10 is the famous vagus. So the nerves, I'm talking about the nerves which are innervated in these 3 places, that is midbrain gives rise to 3 and 4. So pons gives rise to 5, 6, 7, 8 and medulla 9 and 10. So the important here are, the things we are going to discuss here in this are 3, 7 and 10 and S2, S3, S4. So 3 is nothing but oculomotor. I'm writing here again because these are important. And 7 are facial and 9 glossopharyngeal and 10 vagus. So this oculomotor nerve forms ciliary ganglion, and this facial forms 2 ganglions, that is submandibular and also pterygopalatine, and glossopharyngeal forms optic ganglion, and vagus forms terminal ganglion, and the sacral also forms terminal ganglion. So yeah, this ciliary ganglion innervates into the smooth muscles in orbits, mainly 2, which are constriction of pupil, that is pupillary sphincter, and ciliary muscle. So next one is submandibular. It innervates into submandibular and also sublingual. What about parotid? Yeah, we'll see later. And now pterygopalatine. This innervates into lacrimal gland and nasal and oral mucosa too. But lacrimal here is important, and this one, the things which I underline are important. And optic ganglia, it innervates into mouth and parotid, but it is not important clinically, because if we have any lesions to this ganglions, will have the effect in this respective places, but not in case of parotid. That is why this is not important clinically, but it's important, not clinically. I hope you understand. And the terminal ganglia, it innervates into thorax and abdomen, like foregut and midgut. And next, terminal ganglia. Terminal ganglia of the sacral region. So this innervates into hindgut and pelvic viscera. Mainly the things to remember here are it innervates urinary bladder and also some erectile tissue and rectum. So the clinically important disease here with this sacral region are, I'll tell you, I think you might guess that. If not, obviously I'll tell you again. The neural crest failed to migrate to this rectum, causing what this is important, that is Hirschsprung's disease. This is mainly seen in Down syndrome patients, and also this results due to the missing of this terminal ganglia in the wall of the rectum, so that infants cannot pass this meconium. Yeah, that's it. And next, coming into the parasympathetic nervous system. So yeah, this is roughly I drew this sympathetic nervous system. Yeah, it might be funny. Okay, love, I don't mind. But the important thing I care about is you remember this. So you might be thinking what this red color structures here. That is, I told you that it is DHT, descending hypothalamic tracts. So yeah, what controls here is hypothalamus. So this structure you can see here, what it is and what is completely this one. This is paravertebral chain ganglion. We can tell it as a sympathetic chain ganglion actually. So yeah, this has superior cervical ganglion, middle cervical ganglion, cervicothoracic ganglion, and also these innervates into smooth muscles. That is, main function of the sympathetic is to innervate the body wall, that is smooth muscle and glands and foregut and midgut by prevertebral ganglion here. And also this L1 and L2 here innervates to smooth muscles of hindgut and also pelvic viscera. Actually, I forgot to tell you that sympathetic is nothing but thoracolumbar outflow, because it consists of thoracic segments T1 to L2, that is spinal cord levels. It has the spinal cord levels of T1 to L2, that is thoracic nerves which are T5 to T12 and also L1 and L2. So these spinal cord segments are called paravertebral ganglion, and these thoracic and lumbar segments are called prevertebral ganglion here. So next one is this paravertebral ganglion innervates into the smooth muscles and glands of body walls and limbs, head and thoracic viscera, and this T5 to T12 innervates to form smooth muscles, glands, and foregut and midgut, and L1 and L2 forms innervates to smooth muscles, glands of pelvic viscera and hindgut. Foregut and midgut, hindgut. That's it. This is head and thoracic viscera. So here we can see now what are these? These are nothing but the sites of lesions. So yeah, the sympathetic, if you hear the word sympathetic, just remember the two terms, that is these innervates into the body wall and also these causes, very important, Horner syndrome. Horner syndrome, that may be central, peripheral, painful, whatever. So now let's see this in detail. What happens if we have a lesion at here, that is in descending hypothalamic tract, and this results in central Horner syndrome. So I'm writing here THT, lesion results in central Horner syndrome. Yeah, I even told that it has peripheral and painful. So how we can differentiate with this central Horner syndrome and peripheral? Because this central Horner syndrome has CNS with tract sign. CNS with tract sign, we can see other tract signs. So that is how we differentiate this DHT syndromes, lesions. So yeah, now if we have any lesion here, that is, here these obviously innervates to heart, trachea, bronchi and lungs. So if you see any lesion here, or if you see a patient who has Pancoast tumor or apical lung neoplasm or extracervical ribs and all, that comes under peripheral Horner syndrome. So these are preganglion. So I'm writing preganglion, Pancoast or apical lung neoplasm, that is peripheral Horner syndrome. So just remember that this okay. Next, what happens here if a lesion occurs here, that is in postganglion? You can tell here we'll be having internal carotid artery and also external carotid artery. So we can see this famous carotid arteries. If a patient undergoes any carotid dissections and all, they might be having a chance of painful Horner syndrome. Painful Horner syndrome here. Next one is this one, that is if a patient undergoes lesion here, that is T1 to cervical ganglia, or the patient might have some changes in face, scalp, orbit path, that is from T1 to superior cervical ganglion. What does this superior cervical ganglion do? This elevates the eye muscles due to this sympathetic innervations. These are also called as Muller's, but it is better to call this as superior tarsal muscles, superior tarsal ganglion. So Muller, okay, but superior tarsal is very good instead of this. So what happens here, that is pre or post ganglionic innervations that results in peripheral Horner's syndrome. So the classic signs or markers of this peripheral Horner's syndrome are ptosis, three O's, that is ptosis, meiosis, and also anhydrosis. So what are these? We'll come to this later, but first the important classic sign is whether it is peripheral or central Horner syndrome. It doesn't matter. The signs are always ipsilateral. This is very high yield. Just remember this as ipsilateral always. Ptosis is nothing but drooping eyelid, and meiosis is constricted pupil, and anhydrosis is loss of facial water. Anhydrosis, loss of water. We can know that. And this is it about this sympathetic. So yeah, let's discuss about next topics, that is histology of nervous system and also ventricular system. Get ready for day 2. So if you like this video, please do like, subscribe, so that if you have any queries you can contact me and open for suggestions and all.